Welcome to the podcast of HemaSphere, the official journal of the European Hematology Association. HemaSphere's podcast presents insightful, expert discussions about recent hematology publications. We hope you enjoy.
Welcome to this episode of the HemaSphere podcast. My name is Stephen Hibbs, and I'm a hematologist and clinical research fellow based at Queen Mary University of London, and I'm one of the scientific editors for HemaSphere. So today I'm joined by Adrián and Juan, who are both hematologists based in Spain, and they've recently published a HemaSphere paper entitled Machine Learning Improves Risk Stratification in Myelofibrosis, an analysis of the Spanish Registry of Myelofibrosis. And I'm really glad today to have them join us, both to hear specifically about this study, but also to think about machine learning more widely and its potential to change practice. So my first question is to Adrián. I'd like to ask you, how did you first come across the method of machine learning?
Well, this is quite an interesting question. As a clinician, but also trained in diagnostics and bioinformatics, I had quite a good idea about the need for improved prognostication based on further parameterization of the data of patients. So eventually, the solution came out of artificial intelligence. So when you are trying to think about developing complex models that can accommodate complex data from many patients into a single score, then you need some robust statistical technique, and this can be traditional regression models such as Cox, but also others based on machine learning, such as this one, which is based on random forest. So it is interesting, and probably the nice part of this is that you can pick large heterogeneity in patient evolution over time and use that to create a single prognostic score that is quantitative. It's not a prognostic score based on different groups, and therefore the precision is higher and the uncertainty of the predictions are lower than the traditional scoring methods.
And for those of us who are kind of new to this idea of machine learning, and I've got to admit, it's something that when I've tried to read about it in the past has often seemed quite confusing. Would you be able to just kind of describe in simple terms what machine learning is, and perhaps give an example of where it's been applied in a completely different medical context?
Oh, yeah, sure. So there is a broad field of artificial intelligence, and this is quite interesting because the AI specialists don't like the term artificial intelligence. So we have to start from the point that even these experts don't consider this is a clear field, because there is no clear definition of what intelligence is. So assuming that artificial intelligence are all these devices that simulate human cognitive activities such as learning and problem solving, then we have several subfields into artificial intelligence. And the broadest one is machine learning. And this is has become quite common recently, because in machine learning, you have as many applications as your imagination can limit you. And the idea is to train predictors to identify even some hidden layers or hidden variables, in your data. This is unsupervised machine learning, or to be capable of predicting some class or some variable that you know well about such as survival. And this is what we did actually in this paper. And there is a big interest in machine learning, and this has been even broadened by the implementation of ChatGPT. So ChatGPT, the GPT is a generative pre-trained transformer, and this is a complex system that is based on machine learning, but also on traditional mathematics. Mm-hmm. And this has led to the in machine learning. But this is probably more on a very different field, because ChatGPT has been developed to simulate human language and human conversation. However, in our field, we are working on predicting patient outcomes better, to better risk stratify patients, and to better predict, in some cases, drug response, to differential drug response in different oncohematological tumors. So the field is quite different, actually. So when one thinks about artificial intelligence, you have to keep in mind that there are very different domains of applicability. And this requires not just a lot of information or a lot of knowledge about the field, but also a lot of knowledge about the field you want to apply it to. It wouldn't make very much sense to do this work, for example, without the involvement of experts in myelofibrosis, such as Juan Carlos, who is here with us.
So just so I check I understood it. So in simple terms, comparing sort of, I guess, traditional development of a prognostic score would be humans trying out all sorts of different regression models to say, let's put in this and this and this and see how well it fits. And here you're giving a computer the chance to do all those experiments for you and to say, please try out these variables and find what has the best fit. But there's kind of more autonomy given to the computer to do all of those different experiments. So would that be a fair summary?
Yeah, we try to limit the human intervention into the development of the score, so it is not biased by our preconceived ideas about the prognostic factors in myelofibrosis. And this has led indeed to some interesting discoveries that we can further discuss later on. But the idea is basically to be capable of implementing in a correct way these artificial intelligence tools, so as to avoid too much human inference during the tuning of the algorithm, and then to be capable of making an interpretation of the results. And the nice thing is that this is something you can also obtain with Cox regression, for example, but the risk prediction, we didn't want to do closed risk groups, but rather a survival prediction. So we can extrapolate which will be the survival of a particular patient according to the prognostic information compared to the entire Spanish cohort of myelofibrosis in this case. And we also took advantage of the fact that now we can implement these techniques into web interfaces, and anyone can use these web developments to calculate the scores rapidly, which in the past was impossible. And therefore, the past risk scores that many hematologists used to develop were based on scoring systems. That's 1 point for one variable, 2 points for other variable, etc. But that creates a lot of uncertainty in the predictions of some groups. And in this way, by creating an individual risk score, an individual risk prediction that you can then extrapolate into a survival curve, the predictions appear to be much better.
Thank you. So, Juan Carlos, question for you then. I know that one really crucial part of this study that made it possible was the really large Spanish registry of myelofibrosis patients. Would you be able to say a bit more about this and the sort of benefits that have come from having this registry?
Yes, thank you for the question. Actually, it is critical. I'm going to tell you a little bit about the Spanish MPN group, which is GenFin, and it was created in 2011. And the first thing we thought was that it was important to have a registry of all the patients with MPNs in Spain. So we started 3 registries with polycythemia vera, essential thrombocythemia, and myelofibrosis. We got grant from Novartis at the beginning, but then these registries are not funded, so we get cash from educational activities. So it is very researcher guided registry. The industry does not take part on our decisions. And now we have, for instance, in myelofibrosis, 1,800 patients included, which is one of the largest collections of patients with this disease in the worldwide. And in the time, what we have done mainly is to try to assess the results of treatments in real life, treatments that are usually not even approved in myelofibrosis, but are commonly used, for instance, erythropoietin, danazol, or so on, steroids. And also, we've made a few contributions trying to validate prognostic scoring systems that were developed in centers of excellence. And this is what we have been doing. And the good thing about this registry that it has information from patients diagnosed from 2000 till present, and it is still going on, the registry. And we, maybe once a year, we send queries to the centers to try to improve the quality of the data. Although, of course, the physicians are the ones who enter the data in the registry, so there may be difference in the conceptions and things, so the quality of the data in this place could be quicker in some aspects, but it is not biased. I mean, all the patients that are diagnosed in any single center, if they want to put the patient here. So I would say that 60 centers contribute to the Spanish MPN registry, 60, and let's say that 15 centers contribute more or less to half of the population of the registry, so they are big recruiters. But there are many centers that have included 3, 4, 5 patients, so small centers. And I think this information, it is interesting because it gives you a real sense of the prognosis and the treatments of patients with this disease. So it was, I think, a very interesting data set to be analyzed with new techniques like the one that Adrián and you and offer us at that time.
So when you first heard about this and sort of the idea of machine learning and using it with this registry that you've been working on for some time, what was your hopes for what might emerge from this particular piece of research? I'll ask that to you first, Juan.
Yes, actually, well, I'm managing patients with myelofibrosis from the beginning to all sorts of therapies, including transplantation. I also a transplant physician. And transplant is the only curative treatment for this disease, but it's very toxic. The transplant-related mortality goes nearly to 30%, and this is 1 year after the procedure, in the first year. So it is you have something that is curative, but on the other side, it can kill the patient. So the decision to send a patient to transplant in such a chronic disease like with myelofibrosis, which is very heterogeneous. Some patients live more than 10 years, 15 years, and others are really ill from the beginning. The decision has to be based on as much information, prognostic information as you have. And it is usually it's commonly said that in myelofibrosis we have many more scoring systems than patients, but actually the reality is that none of them works perfectly, of course, and you have to base your decision in the information that you have, which is not always complete, and the patient is in different clinical settings, not always in centers of excellence, and you may not have cytogenetic studies because there is a dry tap, you don't have so. And so there is still a need for more accurate tools. And I thought artificial intelligence could be one of those because it can give you an individualized prediction. And it takes into account what Adrián has said. Everybody knows that the number of blasts in myelofibrosis is very important prognostic features. And in the scoring system, you have a cutoff of 1%, 2%. But it's not the same 2% or 5% or 10%. And in this type of platform, you can account for these important prognostic values. So I thought it was a good opportunity to try to test. I don't think this is the end of the road. Of course, we can improve this, but it was like a first experience in myelofibrosis, and I think it was very important, worth publishing it. Although we have to struggle a little bit with the reviewers, I should say.
Yeah, okay. And what about you, Adrián? When you were first kind of conceiving of this idea, what did you hope would come from it?
So at least, at the very, very beginning, I thought this was a very interesting opportunity to work also with the Spanish group. They are a very professional group of colleagues. And although I don't have so much experience in treating myelofibrosis because I'm clinically focused on other lymphoid disorders, I thought this could be a really interesting project because I perfectly knew that the scoring systems that are traditionally used in myeloid disorders, and also in lymphoid disorders, and even in myeloma are working quite suboptimally because they don't exploit the full granularity of the data. And this limits the reproducibility and creates great uncertainty about some predictions. And this is just to mention, for example, the patients with myeloma who are classified to the intermediate risk group in the revised ISS, that they have huge heterogeneity in their outcomes, and this happens over and over in different disorders. So we thought internally that this was a great opportunity to exploit simple information that is available to any hematologist taking care of any patient with myelofibrosis anywhere. You just need a hemogram and a patient to apply the model, and to create a new machine learning based risk scoring system that uses data from a very diverse background of centers. As Juan Carlos mentioned, this is important because this is expected to be much closer to the reality of patients in the universal healthcare system, as compared to only prognostic systems that are developed in very particular centers. And the other thing that I found very interesting at the very beginning was to evaluate to what extent was this phenotypic information, because in myelofibrosis you have a lot of information about the phenotype of the disease with a hemogram. So to what extent was this providing information that could be overlapping with genomic mutations? So to what extent do we need the genomics to risk stratify patients or not? And this is obviously not a question of not yes or no, but there is some overlap that you can further exploit with the traditional and simple clinical or hemogram information that was not currently being done. And this was another interesting area of development that we thought could be of interest for many physicians taking care of myelofibrosis patients around the globe.
Just for listeners, just to clarify, the term hemogram is a full blood count. Is that it's not a term I'm familiar with using?
Yeah, sorry, it's that. Yeah, that's it. Blood count. Full.
And so, sticking with you for a minute, Adrián, I'm going to ask you both this question. And Juan Carlos has already alluded to the difficulty at the kind of review process. But just kind of thinking about this whole project, I'd be interested to know what's been the most sort of challenging aspects of seeing a project through like this, from its initial conception through to getting it published and beyond. But what would you say has been the most difficult part for you, Adrián?
The first interesting point was an internal debate. So with the hematologists involved in the Spanish group, because there is a need to do change in mindset that needs to be done progressively and with a lot of discussion, so we can all get accustomed to use the same language and to accommodate our expectations about the technology. And then once we've done this, we started to work with the data, we obtained some interesting models, and we started to filter out some information. That this is very important. I mean, you can't do this project without cooperating with the specialists in myelofibrosis, because some of the information in the database had some limitations in its interpretability, and this is something that needs to be accounted for. And then I think once we achieved the final model and we prepared the paper and submitted it, so the main limitation that we found is the lack of available reviewers capable of making a high quality peer review of such type of paper. And this is not their fault. I mean, they are not prepared for machine learning yet. So probably the people who are doing the greatest developments in AI technologies are all very young. And however, in the medical world, it is the other way around. So the seniors are the leading key opinion leaders, the reviewers of the papers. So there is a need to develop some kind of specialized information technology reviewers in this process. both to ensure that these papers are reviewed correctly, but also to ensure that the results are real, because there can be some biases, wrong development of the machine learning models, etc., that need to be accounted by these specialized reviewers or senior reviewers or whatever.
Yeah. And anything you'd add to that, Juan Carlos, of kind of difficulties and challenges along the way with this project?
From my part, I would say the first part would be the quality of the data, because it includes a long period of time. So, for instance, the criteria of diagnosis of myelofibrosis have changed over the time. For instance, the assessment of the bone marrow fibrosis criteria have also changed. So, how we could analyze this and how could we say we have to think about how to analyze this type of data. This was one particular problem, and the other one was the kind of preconceptions that some reviewers have, and I also have as well. So we have the preconception that genomic data is crucial, and it seems that almost everything can be explained by the genomics. Although with trying to do this analysis, we noticed that also the basic blood cell counts and the clinical characteristics also reflect the genomic data. And we had, for instance, information of driving mutations in 80% of the data set, 80%, and it was not included in the final calculator because it did not add any additional information to the prognostic value of clinical hematologic parameters. And trying to understand this and trying to explain this to the reviewer was a tough job, I think. And then, of course, we have certain limitations. We didn't have information on additional somatic mutations in many patients, and I understand that this is a limitation of the study. But the first one, I mean, everybody thinks, okay, if you have a calreticulin, myelofibrosis is best prognosis, and it should be included in the model. But actually, we tried that, and it did not add anything to the model. With simple variables, without cutoffs, we were able to do accurate predictions. And the first one who had to try to understand and digest this is ourselves, I mean, myself as a clinician.
Yes, that's fascinating. So I guess there's it's almost a challenge to some orthodoxy here, really, of everyone has got used to leaning quite heavily on genetic information. And after a while, I guess you develop a sort of strong attachment to that as being, definitely the way forward. And here, the humble full blood count hemogram has, with some clever computing and mathematical modeling, done more heavy lifting. And yeah, it is a surprise, and I can see how that is a difficult. Surprises are difficult, aren't they? And so that's fascinating. So can I ask for you then, Juan Carlos? Now you've got this model, and you mentioned it's the start. It's not the end of this work. Does it change for you either the decisions you're making or the conversations you're having with patients in clinic with this incredibly difficult decision about who you take to transplant or not? Or are we not there yet for this being sort of practice changing for you?
Well, it's not a practice changing, but it is another tool. And I'm using this in the conversations that I have with my patients. So I'm using definitely this prognostic scoring system. But in our recommendation in the paper, we said that at the time being, this difficult decision should not be based in one scoring system. You need to have more information. And in particular, we still think that the molecular data are important, particularly regarding the risk of acute transformation, which is something that you should avoid. And if the patient is high risk, try to avoid this transformation. And molecular data I think are important for that purpose. So I think in the future we should develop a kind of updated model when all the patients have enough clinical and molecular data, all the patients, and then we try and we assess the real value, prognostic value of each of these features. And I think this should be done. I don't know in which setting, but in the next year. But we cannot say, okay, we are happy with the conventional prognostic models and that is enough, because as Adrián said, I mean, this techniques gives you a lot of opportunities, and we are watching every day in the radio and TV that is disruptive technology, is changing the things. And I think we have given readers a view of that, and I'm applying it in clinical practice at this time.
Thank you. So, Adrián, I just want to pick up one thing you'd said when you were talking about the review process here, of the importance of having people who could look at this quite complicated work or complicated, specific, specialized work. And I particularly wanted to touch on this idea of algorithmic fairness, that we're aware increasingly that of socio-demographic disparities in people's outcomes. So depending on your socioeconomic status or your ethnicity or all sorts of other things that in theory shouldn't have much to do with your outcome, people's outcomes are different, and how actually certain models in medicine can make that worse. So a sort of high profile example was about chronic kidney disease scoring. And I've heard it said that with machine learning, that can be even harder to spot, because the computer's doing so much of the work. You might end up with a model that is only fair or useful for some patients, but for others, actually, it doesn't work, or it's not representative. Is this something that you've had any thoughts about in this area?
So I totally agree with your view, because one of the things that you need to be very careful about with AI tools is overfitting to the structure of your population in the training cohort, and the possibility of including some biases that you cannot account for. So this can also happen with statistical tools, but it's not so severe as with machine learning. So we actually introduced some techniques to account for that, such as cross-validation and external or trained test split validation. And we are very happy because this Italian group has recently reproduced the superiority of the prognostic scoring system compared to the IPSS. But anyway, we need to be very aware about the possibility of some biases occurring in any population. We believe that in this case, this should be minor. At least biases related to socioeconomic status are not so severe in Spain, because as in other parts of Europe, the healthcare system in Spain is public, and we are incorporating data from very different backgrounds, from small hospitals to large academic hospitals that we think represent the reality or is very close to the reality of the myelofibrosis in a developed country. But we also need to take into account that, for example, differences in treatment availability will make it difficult for any model, not just this, but any model to externalize to another country. For example, from 2012 onwards, these patients could be treated with JAK inhibitors, and maybe in other countries, in the second or third or developing countries, these patients might not have access to JAK inhibitors, and therefore the machine learning might be over or underestimating the risk of some of these patients just because they don't have the availability of this drug. Because in Spain, if the patient progresses, you can add the JAK inhibitor, and the patient will probably have a response and prolong his survival. But this might not be the same in other countries. So there are a lot of implications of these prognostic scores. And when trying to incorporate them into a different environment, at least a very different country with a very different socioeconomic background, we might need to share not only the algorithm, but maybe to share also methods, so they can develop their own prognostic scoring systems if this is of interest for them, with the data that is representing their country. And for example, another thing that can have an impact is that these patients have a long survival normally, although very heterogeneous. Many of these patients live very longly, and average life expectancy in Spain is huge. I mean, I think it's over 83 or 84 years, and it's difficult to know if this will generalize to countries that are whose life expectancy is 10, 20, or even more years less. So these are things that need to be accounted for when dealing with survival models, and maybe this is just the starting point in the field to further discuss this with our peers in the big conferences.
Yes, great, thank you. So I guess my final question is sort of the blue sky thinking question, and I'll come first to you, Juan Carlos, for this one. If you could have unlimited money and access to the data for all myelofibrosis patients anywhere, everywhere, what would be the one question or piece of research that you'd want to do to try and forward our understanding of prognostication in myelofibrosis?
Well, I would create a huge data set of clinical and molecular data, and I will ask this data set not only about survival but about risk of acute transformation in the following 2 years after the clinical factors. And with this, I think we could improve much better our transplant decision making based on prognostic data. And I think this actually can be performed in the next years. I mean, it's not a chimera or something like that.
Brilliant. And to you, Adrian, anything else you'd want to add to that?
Yeah, I could try to add some, as Juan Carlos said, the key is to add more information, surely. But I would also try to add histological information. We can now digitalize the slides of the bone marrows and extract features, both quantitatively or even complex patterns that can only be derived from computer vision tools, which are very complex, that can also add some prognostic relevance. I could also include follow-up data so that we can make the model more dynamic. So a patient after 2 years can recalculate the score according to the previous evolution and make an expectation of survival for the coming 2 or 3 years. And maybe I would also try to put this into correlation with the response to disease-modifying agents such as JAK inhibitors. This could be also of interest. So a multi-functional approach. Brilliant. Ideally, obviously.
Yeah, no, thank you. And I guess when you're dealing with sort of such, it's almost like you're dealing with a nuclear button option of do we go to transplant or not? And it's such a massive question that I guess anything that's going to help along the way is going to be worth investigating. That's brilliant. Well, thank you both. I feel like we've learned a lot today about, I guess, thinking about this question of transplant decision making, learning about the possibilities of machine learning. I think learning about challenging orthodoxies, as you have by showing the full blood count, can sometimes give you as much, if not more, information than genomics. And to think about some of the road ahead and some of the things we've got to be a bit careful of in complex models like this. So I'm really grateful for your input, and I just want to highlight to any of our listeners that the paper is available on the HemaSphere website to have a read of and to learn a bit more. Thanks all for listening, and we'll be back with another HemaSphere podcast episode soon.